Boa tarde a todos, pessoal. Eu sou a Graziela da Molinha. Eu queria que todo mundo continuasse bem à vontade aí no seu almoço. A gente vai seguir essa próxima mesa em paralelo, somente para a gente não atrasar tanto aqui a nossa programação. Fiquem à vontade, tem sobremesa lá fora e o pessoal também vai servindo as bebidas. Nesse momento, então, a gente vai agora mudar o foco um pouquinho do nosso tema desse bloco. Então, a gente volta a falar sobre pesquisa clínica. Eu sou oncologista clínica, eu sou a vice-presidente do Grupo EVO, extremamente feliz de estar participando desse evento, com tantos amigos e colegas. Então, o nosso módulo, nesse momento, é como a pesquisa pode ajudar e como conduzi-la na América Latina. E aí, então, a gente vai ter a nossa primeira palestra, que vai ser a experiência em ambientes de poucos recursos. Para isso, eu vou convidar a doutora Asima, que ela é oncologista ginecologista, ela atua no Reino Unido e também na Índia, com a sua especialização em ginecobstetrícia e oncoginecologia em Londres. Dr. Asima, thank you so much for being here with us. And now we'll learn and understand more about the experience in low resource settings. Thank you.
So hello, everybody, again. And we'll talk about research in the postprandial session. And I know we're short of time, so I'll be brief and skip a few slides as well. So I was talking about challenges, but we have heard about so many challenges. So I think I like to offer some solutions as well. So just kind of talk. India is the cervical cancer capital of the world. One woman dies every 8 minutes. A single country contributes to 20% of the cervical cancer cases and 23% of the global mortality. One thing important when talking about research, as you can see, the red countries where communicable disease is more important or more of a problem than non-communicable disease. And this is where, and even within the non-communicable disease, heart disease, diabetes, they're more common in cancer. So this is how the research prioritization will happen in terms of publicly funded research in a given setting. And this is very important because the blue ones are where cancer is more common, but the red ones are where communicable infectious disease is more common as a problem, public health problem. So we do have studies in India. I'm talking about India as a setting. So we have single center large clinical trials. We can do them very fast. That's no-brainer. But more commonly, we have single center, small retrospective or prospective studies and data amalgamation, which is easy to do and more commonly done. What we would want to do and want to build up and where we are struggling or trying to find out a solution is doing multicentric RCTs to generate an evidence within the country and being multinational. Can we do big trials? Yes, well, we have had trials in screening, 30,000 patients, 142,000 patients. And this is in VIA, and I like to take this opportunity to really pay a tribute to Professor Shankar Narayanan, who did all these landmark studies on VIA, and he sadly passed away last month. So it's a great loss for us, but he has taught us a lot in terms of doing trials in India. Something else I wanted to say, we talked about the single-dose vaccination being evidence now, but just wanted to tell you that evidence was a serendipity. The randomized control trial stopped because of public problems, and the arm where there are girls who received only 1 dose of vaccine and then the trial stopped, they were followed up generating evidence. So it's not always randomized control trials are needed. This is an important slide. This is where I was recruiting patients from Centicol and Interlace. And as you see on the left-hand side in a national cancer center, 10 years ago, the annual report 42% of the patients are stage 3B. 10 years later, when we were recruiting in Centicol and Interlace, you still see stage 3 becoming this is a screening log. This is still the most commonest presentation. And we have certain different profiles. We do have a reduction in the caseload for eligible for radical hysterectomy post 2018 because most of them have some lymph nodes somewhere and they're stage 3 now. And 25% of the patients who are supposed to receive CCRT because of big tumors, obstructive symptoms and all, they don't receive the platinum bit of it. And palliative chemo and recurrent setting often faces the challenge because you are competing with curative intent chemotherapy for ovarian. So these are all the resources that we need to think about when planning research. So what are the ones which are commonly more acceptable? The ones where there are long waiting time for radiotherapy. I mean, these are some of the trials that people think that we should be doing, and there is attraction for those brachyschedules. But the ones which we would struggle is if we want to do something on fertility sparing, because that is not a major issue for us, and so on. So it's very important how we sell. There are several recruitment challenges. We all know, most importantly, we discussed yesterday, many of our patients don't like the idea of being randomized because they don't understand it. And also willingness of a provider. Most of the facilities are centered in private setups, but they wouldn't want to do an academic trial because we have industry-sponsored trials as a competitors. In the government centers, you have a lot of patients, but there is not an infrastructure to do good quality data generation. There's also one thing very important, like when I work in the UK, you do have a PA or programmed activity or incentive for recruiting patients in academic clinical trials. It's in your job plan, but we don't have those for practicing clinicians in many low resource settings. So research is an additional burden sometimes. Very important to understand that. De-escalation versus escalation studies, it's very important to understand that some studies may be sold because it's de-escalation of morbidity, like de-escalation of lymphedema, de-escalation of morbidity of shape, but it is actually an escalation of resources because the intervention is not only what you want, it is intervention of that plus high quality diagnostics. And that bit often remains missed. So you want to talk about de-escalation of lymphedema. However, it is with escalation of high quality imaging, pathology, and this is what also needs to be taken into consideration. However, every study is a small step, but a giant leap in terms of services initiative, number of women benefited, quality assured protocols developed, and therefore it's almost like a tertiary outcome measure, and it's always useful to have these trials. A couple of points about standard of care. Now, what is a standard of care in a low resource setting? It is often a patchy adaptation of what has been told. So therefore, there is actually two control arms. One is your control arm if you're your own setting. One is the control arm of the trial protocol, and then you have an intervention arm. And most of the time is spent on catching up, of making your control arm their control arm, and therefore time needs to be allocated for that. This is how I do advocacy for planning a trial. It has to fit into one box. If it would either improve survival or strategies of treatment like infrastructure or maybe impact on policy making, quality of life, reduction in toxicity, very important, financial toxicity. That is a great indication for us to take on a study, capacity building, or building up young investigator programs. So this is what we thought as a solution we would do. We have 8 CCRN sites within India, but it is time to really come together and ask what is relevant for us. Which endpoints? What quality adjusted endpoints? What are the challenges in doing? the studies and how do we brainstorm and build up our strategies. So this is collaboration, and I think this is something we should be doing. Very important, know your own biology. We always read the TCGA data. We're forgetting that 75% of the patients in the TCGA on the cervix are specimens of radical hysterectomy in early stage cancer. We did a TCGA equivalent in India. 75% of our patients are advanced stage patients. And if you see the biology, we do have differences, a lot of PI3 kinase mutation, distinct immunological subtypes. So we really need to focus on what is relevant for us and design our studies to suit the biology. So better biology, better clinical trials. We have larger tumors, hypoxic, so we're looking into alternative radiosensitizers, IO trials. We do have distinct immunophenotypes. Maybe we have to think about which population, select them, and then dosing, I'm going to talk. And very important, innovative trial designs. We do not have the resources to do trials after trials after trials, so we really need to be thinking innovatively how to do one trial if we get the funding and get all the answers that we need. Have I got 5 minutes? That's great. Very important to consider, we always based on our PFS or OS based on an intervention, as if the intervention dictates the survival. In low resource settings, what dictates survival? It's a combination of a tumor, macro environment, and the resources. I called it TMR. And this is more important. It's not the intervention, so when you show those graphs separating and you think it's the intervention separating, we have to think about these as well. Very important factors for us. We need pragmatic studies. Yes, 5 minutes. Pragmatic studies, and if you put what you mean by pragmatic, they all come in a pragmatic mnemonic. And basically, it's a practical, we can't do big studies, or I call it an R2CT strategy, which is rationalizing and reducing the cost of running randomized controlled trials. Rationalizing, because not all questions require a big fat RCT. We can be smarter here. Master protocols combining triangulation of evidence, registry-based RCTs, trial within cohorts, implementation research. These are all innovations which we are in a position to adopt in our practice in terms of generating evidence. Very important site selection. One of the reasons for pragmatism in India is inclusivity. I don't want any center, any site, government, rural, state, to be excluded from participation. So don't make it too complicated. It will not be generalized even in your own country. So this is we've developed a site feasibility score matrix. If you score low in the matrix, we will not exclude you. We would put you in a survey or a single arm or a registry while you build up the capacity to be included in an RCT later on. And this is an example. I just have 4 minutes. We're doing a low-dose study, low-dose trial in PARP inhibitor in ovarian cancer. We adopted the principle of pragmatic studies, single research question, umbrella studies, but most importantly, so we've done some preliminary lab data, exploratory cohort, and then going into a phase 2. But we realize in randomization, as you said, our patients don't like to be randomized, especially if you want to be randomized into a toxic, non-toxic, highly financial toxic versus non-toxic. So we have designed in a way that in one single trial, you have an option to be recruited in randomized as well as non-randomized option. So basically, if you're eligible, you sign, we are giving choices, patient cards, randomized, non-randomized, single arm, physician's choice. So basically, every patient walking through the door can get any of those, and they all become their contemporary controls in real life, real time. So non-confirmatory, contemporary controls, and you can get data to compare. If they get into the randomized, brilliant. If not, we still have meaningful data. And this is where we collaborate. We done an intermittent dosing in PARP. We done some studies in cervix, so using PARP as a radiosensitizer. But again, we will use the same model. We've done lab science. We know it works in big hypoxic tumors. Over the years, intermittent data on using PARP is there, and therefore we will do this, but after doing surveys and, all following the principle. Another, we talk about dose, duration, schedule, immunotherapy. Again, same principle of the intermittent PARP in ovary. We're wanting to do a study called LOPERA in cervix. The generic of pembrolizumab will be available in India in January, so hopefully we should be able to do this one. And it's done by one of our young investigators, and she's scratching her head now. But of course, she will be following, again, patient involvement, surveys, patient survey, physician survey, translational studies, then go on to the survey. It's very complicated, but we're working through innovative trial designs, and this is using a practical design of practical margin of inferiority, trying to ask all three questions in one study. This is an academic freedom that we have in academic studies, and we should use some of them. Another example, when you don't have brachytherapy facilities, I talked about yesterday, whether we can do something else, replacing brachy with surgery. We call it debracha. But again, umbrella study, high resource setting for RT, you do something. If it's a low resource setting for radiotherapy, you have other studies going on. Again, we will use survey, prospective validation, step by step. Just last slides. So there are two reasons, if I got a minute, that you would want to do a study in a low resource setting. One is a tick box exercise. Big fat studies, they will not publish if you don't have a low middle income country representation. Will they pay money? You will do the study, right? So that is one way. The other is really there is a study originating in the developed country, but you want to be robust. That's so that it works in every setting. There are two options. Either you adopt a pragmatic approach, or you create a Cinderella story of an artificial environment to create an quality assurance, which is not practically. The Cinderella, so the clock strikes 12 and you are back to square one, right? This is what happens most of the time, and it needs to be given time, or use a pragmatic approach. Last slide. The more important things are trials which are really, really designed to address low middle income countries' specific problems and questions. And this brings enormous opportunity for innovation. And I would stop here, and hopefully we will collaborate one day. Thank you.